COVID-19 in Black America. Let's talk about it. Greetings. I'm Dr. MicahJohnson. Please bless me with a quick like, subscribe, and comment. And I promise you, within a few seconds of you doing that, you'd have helped me catapult my career to the next level. I'm a sociologist trained in epidemiology and criminology. Two of my driving principles are social justice and peace building. And in that regard, let's talk about COVID-19 in Black America. One of the most critical and urgent public health concerns is the impact of COVID-19, this COVID-19 pandemic, on vulnerable populations. It is essential that I disseminate a basic analysis of COVID-19 in Black America, given the unique history and extreme vulnerability associated with this population, particularly from a sociological and epidemiological perspective. There is limited data on COVID-19 by race and ethnicity, but preliminary data indicate frightening disparities. We have some data at the state and federal level. In a CDC report, among a sample of nearly 15,000 Americans whose COVID-19 infection was confirmed by laboratory tests, Blacks were 18% of the sample, but 33% of those who were hospitalized. In Chicago, Blacks make up less than 1/3 of the city's population, but represent more than half of the people who tested positive for COVID-19, and nearly 3/4 of those who died. In Illinois as a whole, Blacks and African Americans account for only 15% of the state's population, but represent over 40% of confirmed COVID-19 cases and nearly 30% of those who died. Similar trends based on limited preliminary data have been observed in other states, including North Carolina, South Carolina, Michigan, Connecticut, Louisiana, and Georgia. I fear that these may be underestimations. Unfortunately, there are some indications that these disparities may actually be underestimated. State and federal entities have been extremely reluctant to release COVID-19 cases and fatalities by race and ethnicity, possibly because it would be a political nightmare. Anecdotal and epidemiological evidence suggests that Blacks are less likely to have access to testing services. If people die due to COVID without a diagnosis, the cause of death will not be COVID, but attributed to some other comorbid condition. The CDC has advised that medical examiners, coroners, and other healthcare professionals use their best judgment to determine if a decedent or someone who has passed away had signs and symptoms compatible with COVID during their life, and whether a post-mortem examination should be pursued. I am not optimistic that the CDC's recommendations will result in post-mortem investigations among Blacks. Discretion doesn't tend to favor African Americans, and systems are already strained, and there's very little incentive to conduct a post-mortem examination. It just won't happen. Another issue is missing data on race. Data are lacking because many Blacks and underrepresented groups are opting out of disclosing their race during data collection because of the negative consequences associated with being identified as a minority. Again, missing data on race can result in inaccurate or even underestimated findings. Why? Why do we see these racial disparities? A complicated web of numerous potential variables can be summed up in the concept of risk and protective factors. A risk factor is a characteristic condition or behavior that increases the likelihood of getting a disease or injury. They can coexist, cluster, and accumulate. These are the three that concerns me: exposure, predispositions, and services. These are the big three risk factors in regard to the impact of COVID on Black America. First risk factor, increased exposure. The intersection between race and poverty results in dense households and living arrangements. It results in a reliance on public transportation. It also results in prolonged exposure to high-risk spaces due to being devalued and disempowered by employers, requiring these folks to continue to work while their more privileged counterparts enjoyed social distancing with professional and economic impunity. That's why state-level mandates are essential. Second risk factor, predispositions that exacerbate symptoms. Neurophysiological maladaptations to social marginalization and oppression, which include an immune system that has been suppressed by a lifetime of living in a food desert. The weathering effects of cumulative disadvantage, trauma, and stress on the body, mind, and soul. Allostatic load, which simply refers to overexposure of stress hormones that can cause wear and tear on the body's symptoms. Substantial research has linked allostatic load to hypertension, diabetes, cardiovascular disease, and abdominal obesity. These are the key underlying medical conditions that significantly increases the likelihood of hospitalization, severe illness, and fatality due to COVID-19. Third risk factor, disparities in treatment services. The preponderance of scientific evidence illustrates significant racial disparities in healthcare, services, and access. Screening and treatment services for COVID-19 will not be an exception. On the contrary, it may be worse. In the context of heightened anxiety and limited resources, discrimination and racial disparities will be pronounced. History has shown us time and time again, if two lives are on the line, one white and one black, then we should brace for a black fatality. If there is only one ventilator, then the chances are that that black person will have to get their affairs in order. If two people are sick, one white, one black, and there's only one test, then that black person will most likely have to figure it out for themselves. The black-white dichotomy is tremendously oversimplified, but it is real, and it is a quick example of how folks of disadvantaged social groups will have very different experiences during this pandemic. Blacks, minorities, low-income communities, rural and frontier areas, and all other underserved populations need to pay close attention and be intimately connected to the way COVID-19 is impacting Black America. Not only because it's the more moral or American or human approach, but because it is a precursor. You are next on the disparity list. The cascade of care for COVID-19 was not designed for the underprivileged. It was designed for the privileged. Those who were privileged enough to have internet access and some degree of health literacy to know how and where to access services, and those who were more privileged enough to have access to a car or reliable transportation for drive-through testing. Unfortunately, those in digital deserts and those who lack access to transportation will be excluded from these potentially life-saving services. The big three risk factors have resulted in these alarming racial disparities in hospitalizations, severe illnesses, and mortalities. You may be able to survive predispositions or increased exposure, but without adequate healthcare services, COVID-19 can be a death sentence. It is important to note a few protective factors. Political clout, financial resources, a clean bill of health, close proximity to healthcare systems, health literacy, internet access, access to transportation, a trusting relationship with institutions, belonging to a dominant group or a highly resourced social group. Trump said it a while back, the folks that will be fine will be the folks with resources and political clout. I present to you three key solutions. Number one, harmonization of data. Number two, humanize Black, minority, and underprivileged groups. Number three, equitable allocation of resources and services. Number one, data harmonization. combining epidemiological data from different sources to provide a more comprehensive and accurate picture of health disparities in incidence, prevalence, and trajectories with a particular attention to testing services, hospitalizations, and fatalities. I am particularly concerned about folks who are dying without even knowing that COVID was the culprit. Solution 2, humanize. We've struggled historically with this one. Black people in America are the descendants of slaves. We are extremely vulnerable in the United States of America. Blessed, yes, but extremely vulnerable. Victims of unreconciled historical and contemporary trauma, atrocities, and inequalities. Break the cycle of dehumanizing and demonizing Black people. Even as we die, suffocating with COVID-19, we are being demonized as alcoholics and smokers, insinuating that these people have been cursed with COVID because of their corrupt character. Despite the fact that the American Lung Association has consistent data indicating that Blacks and whites smoke about the same rate, and among adolescents, whites smoke twice as much as Blacks. Despite 20 years of research from NIAAA, the National Institute on Alcohol Abuse and Alcoholism, consistently demonstrating that casual and heavy drinking is more prevalent among whites. But when a global pandemic makes its way to the Black community in the U.S., this racist, ancient, and persistent narrative emerges that if Black people only stop drinking and smoking and being thuggish, ruggish, then they will be protected. Deprogram your mind. Get these racist talking points and perspectives out of your mind. They are ahistorical and against research. Even if Black folks were as high as kites, even if we were, to quote the Tear the Club Up thugs, smoked out, snorted out, drunk and blowed,
I'm smoked out, snorted out, drunk and then I'm blowed. I'm smoked out, snorted out, drunk and then I'm blowed.
Humanize us the way you humanize smokers and drinkers in Italy. Humanize us the way you humanize and do our fellow white Americans. Humanize us the way you do the smokers, snorters, and drinkers and blowers in white communities that are also suffering from this virus. Relatedly, let's talk about this conversation about the Black church. Diagnosing the Black church as a risk or protective factor in regard to COVID-19 is very nuanced. The continuum of risk and protection has gray area. Whether a particular church function falls on the risk protection continuum is certain to vary tremendously, depending on church leadership, how well precautionary measures have been implemented. What we do know is that the church is one of the most powerful and central protective institutions, especially for the Black community. Empirical evidence has shown that the church is almost like a secret weapon against adverse health effects of anti-Black racism, of cumulative disadvantage, and social inequalities that are particularly relevant for COVID. Marino A. Bruce is a sociologist and ordained Baptist minister. He and a team of 10 of his colleagues published research in a top-tier academic journal finding that among a sample of over 5,000 middle-aged adults, non-churchgoers had significantly higher allostatic loads scores than churchgoers. More frequent churchgoers had 50% reduction of all-cause mortality risk compared to non-churchgoers. It is important to understand that in the context of underserved communities, marginalization, and strained relationships with mainstream institutions, the church serves as a multidimensional institution in these communities. The church becomes the social club, the political hub, the counseling center, the behavioral health facility, and so much more. Just like the saying goes, for better or worse, Jesus is my doctor, and he writes out all my scriptures. With that being said, yes, certain evangelicals across diverse racial backgrounds have been shockingly negligent, placing their congregation and their own lives at risk due to ego, stubbornness, ignorance, or fear of economic consequences of implementing these public health recommendations. Remember, one of the greatest blessings that we have is wisdom and wise counsel to help us make intelligent decisions. Another topic related to that, related to this concept of humanization. There is a prevalent and false narrative that blacks largely were irresponsible and felt inevitable or invincible to COVID, and this misjudgment brought on their misfortune. This myth persists, despite the fact that Queen Cardi B warned us very early on, coronavirus is getting real. Cardi B's analysis is corroborated by anecdotal and epidemiological evidence indicating that blacks and Latinos were significantly more likely than whites to be concerned about their health and invest in essential supplies in preparation for the COVID-19 outbreak in America. A part of racism is not affording blacks and Latinos and minorities the same adjectives and subheadings as whites. If a black pastor refuses to adhere to stay-at-home recommendations, then all of Black America are characterized by those actions. But when the beaches were packed with mostly white people, they were called spring breakers, and rightfully so. No group should be judged by the actions of a fraction. Solution 3. It is simple and short. Ensure the equitable allocation of resources. We need to ensure that federal and state resources are not being funneled to those with great wealth and great power. Again, I submit to you the impact of COVID-19 on Black America. The solutions are data harmonization, humanization, and equitable allocation of resources. Despite all the risks and obstacles, I want to acknowledge and encourage the overwhelming majority of Black folks that have been adhering to wise counsel, being brilliantly resilient, and strictly adhering to recommendations from public health professionals. While this particular chat focused on Black-white disparities in services and severity, I'm also deeply concerned about other vulnerable groups and will be using my voice to bring awareness to issues facing homeless children and families that live in rural and frontier communities. Again, I'm #DoctorMicahJohnson. Subscribe, comment, and like to help bring awareness to these issues in pursuit of social justice and peace building. Peace.